Good morning, everyone. My name is Dr. Tanvi Mittal. I'm from Sarojini Devi Eye Hospital. I'm a second-year postgraduate. Today, the title of my paper is The Eye Turns Against Itself, Inflamed and Tethered, a rare case of ocular cicatricial pemphigoid. Ocular cicatricial pemphigoid is a form of mucous membrane pemphigoid that features a chronic, relapsing remitting bilateral cicatricial conjunctivitis. It's considered a rare disease with an incidence of about 1 per 10,000 to 60,000. Oral mucosal involvement is also seen in patients of mucous membrane pemphigoid, followed by skin and other lesions in the trachea, esophagus, pharynx, larynx, etc. But ocular cicatricial pemphigoid predominantly is a rare disease. It commonly affects females in a 2:1 ratio over males, and the age of onset is about 60 years of age and older, with no racial or geographical predilection. Coming to our case, a 51-year-old female who was otherwise healthy presented to the OPD with gradual progressive decrease in vision since 3 months, which was also associated with pain, redness, and discharge from both eyes. She also gave history of bilateral conjunctivitis 1 month post right eye pterygium excision surgery, which was performed 2 months back, for which she used eye drops moxifloxacin 0.05% for 2 months. There was no history of ocular trauma, and no other systemic comorbidities were noted in her. On examination, the vision was perception of light in right eye and hand movements in left eye. Both eyes showed matting of eyelashes due to discharge. Conjunctiva showed chemosis, congestion, and symblepharon was also present. Corneal edema was seen, because of which the other details of the anterior segment were not appreciated. According to our clinical examination, we made a provisional diagnosis of a stage 3 ocular cicatricial pemphigoid. Further, we evaluated the patient by doing a B-scan ultrasonography of both eyes, which was normal. Vitals were also within normal limits. Systemic examination was unremarkable. No other systemic lesions were seen in the patient. For further investigation, we performed a conjunctival biopsy from both eyes, and it was sent for microscopic examination as well as direct immunofluorescence testing. The biopsy revealed subepidermal bullae and was devoid of epithelium. The diagnosis of OCP was further confirmed by direct immunofluorescence testing. This patient was further treated conservatively and was referred to a rheumatologist for the management and advised to follow up with us. Coming to our discussion, ocular cicatricial pemphigoid is a chronic, progressive, potentially blinding systemic autoimmune disease, which is thought to be due to a type 2 antibody-dependent hypersensitivity response seen against the hemidesmosomal epithelial membrane complex in the conjunctival basement membrane. This autoimmune response is usually seen when patient has a genetic predisposition and is exposed to an environmental trigger. The hallmark of OCP is a progressive cicatrization of the conjunctiva, which can further lead to progressive symblepharon, ankyloblepharon, pharyngeal shortening, potentially leading to blindness. The gold standard for diagnosis is a judicious conjunctival biopsy with direct immunofluorescence testing for IgG, IgA, IgM, and C3. Positive staining usually reveals a linear pattern in the basement membrane zone of the conjunctival epithelium. But about 20 to 40% of patients may have clinical signs of OCP but have a negative biopsy result, which does not rule out the diagnosis of ocular cicatricial pemphigoid. These patients most likely only have ocular disease, as with our case, as a positive result is much more common in patients with ocular, skin, and oral involvement. Negative results usually could be due to incorrect biopsy technique, concurrent quiescence, or even a disease burnout. Thus, OCP poses a challenge both for diagnosis as well as management, as most cases remain undiagnosed until the late stages because of the non-specific signs and symptoms till the stage of stage 3 symblepharon. Coming to conclusion, an exclusive presentation of ocular cicatricial pemphigoid without any systemic manifestations is very rare. It can also be confused with other diagnoses like Stevens-Johnson syndrome, Sjogren syndrome, graft versus host disease, and other conjunctival scarring disorders. Of those patients with mucous membrane pemphigoid, patients with ocular cicatricial involvement have a worse prognosis than those with skin or oral involvement. Thus, early diagnosis and management are imminent to preserve vision. The diagnosis requires high level of clinical suspicion, especially in cases of chronic, recurrent, unexplained conjunctivitis to prevent the complication of blindness. Management involves a multidisciplinary collaboration between ophthalmologist, dermatologist, and rheumatologist. Thank you.
How would you follow up these cases?
So for this particular case, we had advised follow-up monthly. After she reviewed with the rheumatologist, they started her on methotrexate treatment, and we had advised follow-up 2 weekly. But actually, the patient passed away. We got to know when we followed up the patient, we got to know that the patient passed away, but we couldn't elicit like the cause of the death. A 2 weekly follow-up should be.
You must have done the literature reviews or any such cases without any systemic association?
Yes, sir.
How many? Okay, get it published.
Yes. Thank you.